When somebody says public health economist, what do you picture? Because the first thing I thought about was money. But what I learned was a public health economist isn't really about money. It's about understanding what happens to people in real communities. When a policy changes, when a program gets cut, or when a system was never built to include them in the first place. In this episode of the Healthy Project podcast, I sit down with Jason Semprini. Jason is a public health economist, a lifelong Iowan, and somebody who has spent his career trying to make sense of data that too many people in power are not reading the right way. We talk about Iowa's cancer rates, and y'all, it is higher than almost every other state in the country. We talk about what agriculture has to do with it. We talk about what happens to communities when federal funding disappears. This is not a research lecture. This is a real conversation. And I think by the end of it, you're going to hear your community, your zip code, and your health in a completely different way. All right, let's get into it. Hello, everybody. Thank you for listening to the Healthy Project podcast. I am your host, Corey Dion Lewis. And today's conversation is going to be one of, I don't know if it's going to be about numbers a whole lot, but super important in the way that we think about the economics of Iowa and cancer and all the things and much more. We have Jason Semprini here today. Jason, thank you so much for being on the podcast. I really appreciate it.
Yeah, thanks for having me. Happy to be here.
Yes. So before we get into kind of the conversation today, tell me a little bit about yourself. What gets you up in the morning, and tell me a little bit about your work.
Yeah, I've been consider myself a lifelong Iowan. Grew up in southern Iowa, western Iowa, puddled around the state, and really that's been the kind of the driving force behind the work that I want to do. But I've been fortunate to have an opportunity to use my education and skills I've developed as a researcher to focus on things that are really important to me, my family, and my neighbors.
Yeah, so tell me more about that work. What is a public health economist, and why does that field exist?
Yeah, economists, when we talk about a health economist, there's kind of two camps. One, we try to use theories or models to try to make a complex system simple so we can explain what's going on. An example is supply and demand. Everyone
Right.
remembers what that means from high school economics. And that's an easy way to think of how demand changes, supply might respond, vice versa, or price changes. So that's an example. We create theories to explain something that's complex. What I also do, and what I spend most of my time, is evaluating how a policy or a program impacts the health of people, because that's the kind of evidence we really need to be able to tell the public or tell a policymaker, if we do this, we can expect this to happen.
Right, not just saying, okay, we know we have this problem, but why tackling this problem, why it makes sense for the community to solve it.
Absolutely.
No, that makes a whole lot of sense. And most people hear economist and think about Wall Street, finances. Walk me through what a public health economist does on a day-to-day. What does your world look like?
Yeah, on a day-to-day, do a number of things. So first, we get a sense of what's being talked about by policymakers, by the public. What's an important health topic right now, and what does all the data say? There's a ton of data. We're buried in data right now. We've got more data than we've ever had, but we got to make sense of it. We try to make sense of what's data that can help us answer a certain question. What data maybe isn't so useful. And then we see a lot of studies out there. So before I even begin doing any research on my own, I want to know, well, what's been done before? How good is that research? Is it really answering the question, why is something a certain way? Or is it maybe getting at something, just showing a non-causal or just a pattern that exists but doesn't really inform what we're going to do about the problem?
Ah, got you, got you. And to your point about data, there's something in my work that we try to stay away from, or at least I do, is collecting data just to collect data.
Thank you.
Like, do we need it? Why do we need it? Does like have we been doing this for years? Like, is anything changing in the data? Like, why are we still asking these same questions? Like, all those things, like,
Yeah.
almost in that same frame of like, can this be a meeting or can it be an email?
Absolutely, absolutely. That gets at a key piece of one of these concepts in health economics. It's this the idea of an opportunity cost. So we collect a lot of data. That
Right.
data costs money to collect. It might be harming patients to be overdoing it with the surveys, or at least just makes them annoyed, makes them not want to come back to the primary care. That's the last thing we want to do. So if we're
Right.
doing something that's not causing a benefit, possibly causing harm, and the value of that data, well, we should be doing something else with our time.
Yeah.
So.
Yeah, especially now. And one thing that you brought to my attention that is super, and is super, is a big conversation here in Iowa is cancer and the cancer rates we have. What is that role of a health economist? Like, why are you approaching cancer? What does that look like?
Yeah, I think the role of health economists, myself, and there's plenty of others in the state, looking at cancer, it helps the team of researchers, clinicians, policymakers get a little bit more appreciation of the whole system. Because someone who's treating patients, their goal is to treat that patient the best that they can.
Right.
If someone's screening patients for breast cancer, mammography, their job is to give the best screening that they can to that patient, and then work in a system that can get as many people that need to be screened as possible.
Right.
That's exactly what they should be prioritizing. But when we start talking about policies to reduce the cancer burden, through prevention or early detection and control, that's where we might start seeing some trade-offs that might happen. So we could be really aggressive on certain policies that might not be very feasible to pass, but it also will have some spillover consequences onto other priorities. Maybe we spend less time and resources on cardiovascular disease. Well, is that a trade-off we want to make? We want to spend more time on, smoking cessation,
Right.
and versus other competing priorities, and that's where health economists can come in and help make sense of those trade-offs.
Right. What story does it tell about the state of cancer in Iowa right now?
Yeah, so what we're seeing, and again, a lot of my work is just trying to make sense of all the data that's coming
Right.
out, and there's a lot of people doing really exceptional work contributing that data.
Oh, absolutely.
And so trying to get a grip on what's going on. It's not fake, I guess. It's not like some outlier of the data. Pretty consistent, pretty clear that Iowa has increasing cancer rate. It's higher than almost every other state in the nation, and it's driven by a handful of cancers, like lung cancer, breast cancer, kind of the main ones that stick out. But there's a lot of other cancers that maybe are not as common, like cancers related to HPV, that are really kind of pushing our cancer rate going up. And then, there's always the elephant in the room about agriculture and kind of helping make sense of all of this data to kind of tell a clear, consistent story. It's really the only way we can move forward with any way to address it.
Right.
Yeah.
One of the things I appreciate about what you said, and as I dove into more about public health economists, is it does shine another light on telling the story around and raising awareness around health disparities and some of the things that are going on. So like one of my biggest things with the public health profession, just hop on my soapbox real quick, is how we get messaging out to people.
Absolutely.
Right? Like you can tell me a statistic and I would appreciate it. But, John, who works at, the local grocery store, you tell him that
Oh yeah.
it may affect him more than it affects me, but he may not care or understand that it affects him more. And so like I really, when I looked into it and kind of just how you're breaking it down now, I'm a big sports guy, and there was this show I watched called Pardon the Interruption on ESPN.
Yep.
Love it. And Tony has said this multiple times. The answer to all of your questions is money. Like, we're specifically talking about like sports and stuff, right? But you can apply that to so many things. Is like, if you have a question, like, and you may not think something is important, well, being able to break it down like how you're saying, and it shines a light on what maybe it is doing to the economy of Iowa, or like, hey, this is a big deal and this is why, just adds to that storytelling to make it more real for people.
Yeah. Absolutely.
I really appreciate that. As a public health economist, how do you think about maximizing health across a population? Like, what is that thought process like?
Yeah. So, we think about public health, and I'd say maybe 100 years ago, true public health was, let's make it clean sanitary, clean water, get rid of a lot of the pollutants that are just really causing problems in early development of city living. And that was helping everybody, because everyone was drinking from the water. Now when we think about public health, we still, yes, everyone benefits from public health, but a lot of the interventions now that we're doing are really targeted to people kind of at the margins who don't have access to traditional avenues to getting cancer screening. Okay? So we do a breast cancer screening education program, pop-up clinics, and provide funding for free mammographies. Who benefits the most from that? It's not affluent women who have access to a regular provider who are up to date on their mammography. They won't notice that intervention even occurred, and that's fine. What we're trying to do with that intervention through the lens of public health is targeting people who are not up to date, who could benefit, who maybe don't even know about mammography and maybe don't know about their risk factors. Maybe they don't know their family history and could really benefit from even just one single mammography at a pop-up clinic, because then at least now it's on their radar. At least now maybe in the next 5 years they'll be able to do that on their own without this intervention.
Right. And in some cases, some of those pop-ups is their first time getting any kind of preventative care.
They might talk about a ton more than just the mammogram.
Oh, absolutely.
Yeah,
absolutely.
Yeah.
And so that kind of stuff is really, really important, especially now as we're seeing, some of the resources kind of dry up or get, cut. How does that affect the kind of the outreach to some of these communities? Have you seen anything that's effective?
I've heard from a lot of colleagues that are doing the work on the ground, either in public health or in some of these clinics. And yeah, the money, even if we didn't know it was coming from federal funds, it kind of all trickles from those spots, and it's really starting to hit those areas. And they're the ones doing the kind of the most bang for their buck, you could say, with very limited resources. So any amount of change, talking about money again, any slight deviation off budget can really impact the work that they're able to do.
Right.
But they somehow still trying to keep it going.
Still trying.
Yeah.
You got no choice.
That's right.
You got to keep moving.
Yeah.
What does this is a question just kind of popped up, and what does like a job well done look like in your field? Like when you like, hey, we've done everything we could. We give everybody what does that look like?
Yeah. So a job well done is, again, you've thought carefully about a problem. You've got the data. You've combed through it. You know what's been done and what hasn't been done yet, and then you're able to do what hasn't been done yet. And then it translates not into just a paper that gets published that no one reads. Like, that's maybe my boss might appreciate those papers, but translates into something that's actionable, leads to a policy change, leads to maybe an education awareness campaign or some updated guidance. And an example of that is if you think about the recent insurance expansions from like the Affordable Care Act. Those didn't just pop out of nowhere. Those were tested and piloted at different
Right.
states and communities across the country, and they're like, wow, this is big. This could really move the needle on insurance, and then getting people to a doctor for primary care, doing cancer screenings, other preventative work they wouldn't be able to do without insurance. And that's how it is scaled up. It took 20 plus years from like the first insurance expansion to the ACA, but that's what it takes.
Right, man. We don't think about the time.
Takes a long
time. Like, especially, with someone like myself, where I wanted everything done yesterday, kind of a thing, and like understanding the patience that it takes, and the learning, for a state like Iowa. What makes Iowa so interesting to work in your field? Like, what makes Iowa a good place for what you do, for somebody that does public health economy or economist?
It's a small state, and I'm biased because I've lived here and I left and I came back, and I love the state, but there's quite a bit going on from a health perspective. We've got some of the highest radon underneath our ground that just most people don't know.
We don't talk about it.
Know.
Yeah,
I didn't know about it till a few years ago when I started reading about lung cancer. So that's interesting. We've got this ag economy that's, it's really driving the jobs and finances in our state, but it's also, there's very clear and compelling evidence that it's contributing to certain adverse health outcomes, cancer and otherwise. So it's a tough thing to deal with, and there's no easy solution. There never is, and anyone who tries to make it seem like there's one simple easy solution is probably got an agenda.
Right.
Yeah,
because you bring up a good point. There was this balance in it all, and it's like some of it's good that it's providing jobs and things like that, but also it's killing us. Like it's
yeah.
So what do you do? Also I have a nonprofit, My City, My Health. Save the Homies is one of our initiatives, prostate cancer awareness initiative. And, one of the things that came up in my research on prostate cancer in the state of Iowa, specifically around men of color, it's not that men of color are getting prostate cancer more than others in some situations, but like we're just getting them we're not going as frequently, and it's getting caught at later stages.
Yeah.
And things like that. And as I look at that, I'm wondering how something as specific as prostate cancer in Iowa, which is, I want to say, prostate cancer is the third or second leading cause of cancer in Iowa, right behind.
Yeah, it's probably the most common in men.
Most common in men, right?
Yeah.
But when I think about prostate cancer in Iowa, just after having this conversation with you, I start to wonder, like, well, what else is contributing? Like, what else? How is this? Like, what else is going on in these communities that maybe, someone with I don't have the strongest research background. I know how to do it, but like, what are we missing? And like, how can we tackle something like that?
Absolutely. I think the prostate cancer question in Iowa it's important, and I was shocked too when I saw the rates for black men, especially black men in Iowa. I got a friend his whole dissertation was on this.
Yes.
Gawain Williams. He's awesome. But from my read of it, and this kind of stems back to my as I was trained to be an economist, I also got hooked up with a mentor, Dr. Funmi Olopade, and she's a geneticist, health disparities like guru, and she wrote a book called The Perfect Storm, and it's about biology and health systems colliding to create what we observe for health disparities.
Right.
That was focused on breast cancer, and I think there's something very similar going on. I don't understand why the incidence rate might be higher for black men and why it's more aggressive for prostate, but the navigation to the high quality treatment, which sometimes is a wait and see situation. Sometimes the best treatment might not be too intense, because that could cause some adverse outcomes that disproportionately harm people who, are already facing other health disparities. So that's a key piece that I'm hoping that people keep carrying the torch on in Iowa.
Yeah, yeah. It's sorry, my mind's all over the place. I'm thinking, I'm like, man, I felt like I got to a point where, like, you know what? I have a good grasp of what I think we can do. Like, I have the answer.
Mm-hmm.
I'm super. I got the answer. I can save everybody.
Yeah.
And it's like, oh man, there's more to this than I've barely scratched the surface of what's going on when it comes to specifically that. But we'll have that documentary coming soon. Yeah. I actually reached out to your boy on LinkedIn to interview him for the documentary.
I'll tell him to get his LinkedIn.
Yeah, hey, check your LinkedIn. No, that's good. Yeah. What is one thing you wish more people understood about health economics?
Yeah, again, we're not. Most of the people that I work with, we rarely, if ever, talk about money. We really just want to know how do people change their behavior, whether it's a patient or a doctor or a public health professional or a policymaker, if there's a change in something else. Like maybe we change a policy related to cigarette smoking tax. What's going to happen? What can we say is going to happen from these other states? What do we projected for Iowa? All the way to mammographies. Let's say we make a cost sharing. Let's say we add a cost sharing to mammography.
Right.
What's that going to happen? Who's it going to affect the most? How's that going to affect our cancer mortality rate? Those are the kind of things we do on a normal basis. If you come asking about how much we're spending, well, I'll probably point you in another direction. We spend a lot, but the allocation is another question.
Right. It's just more about the behavior of the I won't say consumer, but like the behavior
people
of
in
the
a system.
people of the system.
Yeah.
Right.
Yeah.
That is so cool to me. And correct me if I'm wrong, but just simply from a population health perspective, like being able to say, okay, we want to target these diabetic patients, right, with A1C of 8 or higher, right, in this specific community. If we do this lifestyle intervention, what is going to happen? Right? Is that kind of like
that's very on point, 100%. Because you can say, okay, we've got these high pockets of adverse diabetes outcomes.
Right.
And we know maybe from claims or from surveys that like this is the key piece that they're missing. And then we maybe know from a randomized controlled trial that's done at Harvard, this lifestyle medicine has an effect. So now we have, how can we scale that in Polk County?
Right.
And then how do we evaluate what worked and what didn't? That's how this could work on the ground, kind of in real time. And that's the kind of stuff that really could make big change, because then you could go say, hey, Lynn County, this is what we did here. Try it here, adapt it slightly, but it worked here.
Right. I'm assuming you have to adapt it depending on the community or the population
100%.
that you're serving.
Yeah, you can't just come in. That's been a critique of some health economics work is, oh, here's this policy or program that works. Just go do it. If you didn't do it right, then that's your problem. Well, no, we got to adapt.
Yeah, you have to adapt.
And we appreciate that now as a field.
So that is starting to make more sense to me. I know before we started even recording, when I was telling you about how I went from Smart Talk to Healthy Project, everybody assumed I was talking about money when I wasn't. And when I hear public health economist, that's where my mind, you must be talking about how an intervention, how it saves money for a health system or for a community or for a state or whatever the case may be. But what I love about it is like it's deeper than just how much money or things like that. That's a conversation for somebody else. How are we changing the lives of the people in that community, and what this intervention or what we've learned, what can happen?
Yeah, absolutely.
That is so cool. What got you into doing this work? Like, what was it that drew you to this?
So I as I mentioned when we were talking off script, I did AmeriCorps for a few years, and then met my wife, and then I went and did the Peace Corps, worked on a health project, and I got connected to some mentors there that said, if you want to keep at it and like keep working in this health space, go get skilled up.
Right.
Get your math ready to go. Be able to do some contribute analytic skills to a team working on a health project. And that led me to the University of Chicago, where I studied economics, and then I caught the research bug working with the mentor that I mentioned, and really just wanted to keep those pathways, this economic and research skills, and really just wanted to do it back home though. So that's where it all started.
Right. Well, I'm sure I was happy that you're here doing the work that you're doing, because it is super important, especially now, especially with the with where we're at in the state, and letting people who have a very important job at the Capitol to help them understand why some of this stuff is important, so we can start, the one thing I'm learning as a non-traditional public health professional is how important advocacy and policy change is so important to the work that I do. Right. So like being able to use what you do and tell that story to somebody who can actually say, yeah, I agree with you, is so important.
Yeah, definitely.
So, Jason, thank you so much for being here. For those that want to connect with you, learn more about what you do, where can they find you?
Yeah, you can just find me. I'm pretty easy to find. I've got my LinkedIn going. I've also got a web page with just my research if you just Google Jason Semprini. So happy to chat more anytime.
Perfect. Well, again, Jason, thank you so much for being here. Everybody, thank you so much for listening to the Healthy Project podcast. I'll holler at you next time. All right, and that is a wrap on this episode. I want to thank Jason Semprini again for being on the show and just having this really valuable conversation with me. It really means a lot. And thank you all for listening. But listen, if this episode hit for you, I need you to do 3 simple things for me right now. First, share this episode. Send it to somebody in your life who needs to hear it, a friend, a coworker, somebody at your church, your health department, your organization. The more people that hear this conversation, the more it can do. That's just a fact. Second, subscribe to Live, Work, Play, Pray. That's my newsletter over at Substack. That's where I go deeper every single week on health equity, the social determinants of health, and stories that don't always make it into the headlines, but absolutely should. I just did an episode on Grandmaster Flash and the Furious 5, The Message. It's really, really good. The link is in the show notes. Go subscribe. It's free. And third, if you're a health organization, a nonprofit, or a foundation doing work that deserves a bigger audience, I want to talk to you. The Healthy Project Media exists to help organizations like yours tell stories that actually reach the people you're trying to serve. There's a link in the show notes to get 30 minutes on my calendar. I hope you use it. All right, that's a wrap on this one. Thank you so much for spending this time with me. This community means everything, and I do not take it for granted. Until next time, keep pushing, keep showing up, keep telling the truth about what's happening in your community. I'm Corey Deion Lewis. I'll holler at you next time.